Thank you. Then my talk is on exercise and overuse injuries. The learning objective of my talk is to provide the significance of the prevention and rehabilitation in the management of overuse injuries. And I would like to present you some evidences and controversies in the care of overuse injuries. As we know, overuse injuries can happen when somebody tries to take too much physical activity and too quickly. This could ultimately prevent you from being active. Find out what can cause an overuse and how to safely increase your activity level. Overuse injuries are a common phenomenon in sport and challenging to assess and manage. Various factors contribute to the development of this type of injury. We know that diagnosis, treatment, and understanding why the injury occurred are some of the challenges that we may deal within the management of athletes and physically active people with overuse injuries. What could be the definition of sport injury? As it was published by Edgar and his co-worker in 2012, sports injury is a damage to the tissues of the body that occurs as a result of sport and exercise. As we know, sports injuries have two big groups. The one group is the so-called acute injuries, and the other group are the so-called overuse injuries. The definition, the term of overuse injury caused by repeated microtrauma rather than a specific or single injury event. The term overuse is used in the onset of this type of injuries are usually precipitated by a period of inappropriate tissue loading, such as 1, excessive magnitude or volume of load, 2nd, insufficient recovery between bouts of load. In these slides, you can see the classification of sport injuries, either of acute injuries or overuse injuries. As you can see, this kind of injuries, and mainly the overuse injuries, can affect all the structure of the human body. Overuse injuries sometimes have the nomination, having the classical nomination of the sports in which the specific movement is very frequent. You can see in the slide that upper limb use the so-called nomination that swimmer shoulder, or thrower shoulder, throwing elbow, pitcher's elbow, tennis elbow, golfer's elbow. Looking at the knee, runner's knee, footballer's ankle. What about the incident of the overuse injury? In our experience, we established that overuse injury, more than 2/3 of all sports injuries. However, the true incidence is not known yet. The principle in overuse injuries are the following. The repetitive microtrauma overloads the capacity of the tissues to repair itself. That leads to inflammation and or local tissue damage in the form of cellular and extracellular degeneration. In this two picture, you can see the inflammation. This is in the first stage, but I'm not sure that always we can experience inflammatory response. And the right side, we can see the so-called real degenerative changes of the Achilles tendon. Concerning the overuse injuries, we can mention the risk factors, which could be also two types, the so-called intrinsic and extrinsic risk factors. Look at these intrinsic factors. These intrinsic factors have also tools, physical and psychological or psychosocial one. And on the other side, you can see the extrinsic risk factor for the overuse injuries. Of course, we should face the modifiable intrinsic risk factors to prevent the overuse injuries. And these are the following: age, gender, somatotype, and previous injury. And there exists the so-called potentially modifiable intrinsic risk factors like fitness level, etc., and the psychological and psychosocial factors can be modified also in a small degree. In the following few pictures, I would like to show you some very typical anatomical abnormalities, like bullocks or knock knees, unequal leg lengths discrepancy is a very special one, that's so-called tibia vara. And we face many times, especially in the adolescent female patient, femoral anteversion, patella alt and patella varia causes always a big problem for us. And flat feet is a well-known abnormality. However, among the physically active patients, the high card, the so-called pace cabus, gives more and more problems. What are the consequences of overuse injuries? The pain, reduced physical performance, reduced sports participation. This influences the athlete, but also the team and sport organization as well. Overuse injuries poses a barrier to physical activity, even in less athletic population, and this has consequences for long-term health and quality of life. Some words concerning diagnosis of overuse injuries. We have to gain a so-called pathoanatomic diagnosis because diagnoses such as runner's knee, as cinch pains, do not clearly define the anatomic dysfunction, while diagnoses such as patellar tendinopathy and medial tibial stress syndrome more precisely define the disorder by pointing to its origin. Overuse injuries have 4 different stages. Discomfort disappear during warm-up is the first stages. Discomfort may disappear during warm-up, but resurfaces at the end of the activity belongs to the second stage. Discomfort at onset of activity and worsens during activity belongs to the third period. And finally, pain and or discomfort all the time is the most serious changes of the overuse injuries. Conservative treatment of overuse injuries have a so-called important aim. Identify and address the cause of injury, reduce inflammation and pain, promote healing, prevent complications, restore normal use of uninjured area, and it's a very important one, develop a return to sports strategy. I think is the most important thing looking at the conservative treatment. May include relative rest and avoidance of aggravating activities. We can use ice and electrotherapeutic modalities. We can use with big advantage the soft tissue techniques. Extracorporeal shockwave therapy, it's questionable. Strengthening the rehabilitation in food one. My colleague, Dr. Rehan, will speak on these issues. Medication such as non-steroid anti-inflammatory drugs, not so useful, especially for the treatment of overuse injuries. And PRP, it means the platelet-rich plasma injection therapy, also a new one, but the real results not yet. Surgical therapy of overuse injury can be performed only after failed conservative treatment, and the time is very important. It means that over 3 to 6 months. We perform surgical therapy when inflammation and degeneration are irreversible and instrumentally evident. It's very important issue. And we perform surgical therapy if surgery is beneficial. And we have to look at the last sentence that we perform surgical therapy only enabling return to original level of sporting activity because 60–80% of all athletes and physically active patients can go back to the sports only after 6 or 12 months. It's a very long time. In the slides, you can see some surgical procedure, like left side, you can see the bottom, iliotibial band release for a runner knee, right side endoscopic carpal tunnel, and down you can see an open, conventionally performed tennis elbow procedure, and the right side you can see the modern or surgical procedure. It's an endoscopic Homan's procedure for a elbow, for a tennis elbow. As this slides and these pictures point out, the practice from the conventional open surgery turned to the very modern so-called endoscopic procedures. What about the return back to sports, which is a very important issue? Traditional athletes have been allowed to return to limited activity when they demonstrate full range of motion. When the injured extremity shows 80 to 90% of the strength of the uninjured extremity, it's very important that it must be objectively measured. And before an athlete or physically active paper return to activity, the physician, coach, and trainer, and the athletic trainer should consider two other questions. Does the athlete demonstrate sport-specific function? And is the athlete psychologically ready to go back to the sport? What could be the future direction on this field? I think that prospective randomized experiments and clinical trials must be performed in a big amount. Of course, development of new techniques are coming. Emerging role of molecular biology, also a very important issue. We can deal with the gene therapy, growth factors, and of course, mesenchymal stem cells therapy. And finally, I would like to give you a take-home message. As it was established by Albert Einstein, knowledge is experience, everything else is just information. I finish my lecture, my talk, and now my colleague, Dr. Rehan, will speak on the prevention and rehabilitation concerning the different overuse injuries.
Good evening, everybody. Can you see me? Hi, good evening, everybody. So today I'm going to present the prevention and rehabilitation for the overuse injuries. And to be quicker, I would like to start directly with the prevention. So the prevention of overuse injuries, there are certain points which need to discuss regarding prevention. And I'm going to share my screen. Okay, great. So can you see the screen? All right. So to prevent an overuse injury, its most important measure is to perform a proper warm-up and a proper cool-down, including athletic training. And other preventive measures include the proper use of proper equipment and to increase the training parameters at a rate no faster than 10% increase per week, including distance, speed, and weight. And special focus on correct exercise technique and conditioning the body for 2 to 3 weeks before starting a strength and flexibility drills. And early identification of management and causes of pain and discomfort is also very important. So the sequence of prevention is divided in 4 steps. So number 1 step is to establish the extent of sports injury problem, and then we head towards establishing etiology and mechanism of injuries, and then we head towards introducing preventive measures, and finally we assess their effectiveness by repeating the step number 1. So what are the preventive measures? So I would like to advise 4 important preventive measures. Number 1 is that whether you are starting a new activity or you have been playing a sport for a long term, consider taking lessons. So using a correct technique is crucial in preventing the overuse injuries. Second step is pace yourself. So if you are starting a new fitness program, avoid become a weekend warrior. So compressing your physical activity for a whole week in 2 days can lead to overuse injury. So instead, aim for at least 30 minutes of moderate physical activity a day. And if you do not have time for full 30 minutes, you can break it down into smaller blocks of activities throughout the day. And the third thing, which is important, is gradually increase the activity level. So when changing the intensity or duration of physical activity, so do it gradually, not too fast. So this is gradual increases is very important. And how much increase? No more than 10% each week until you reach a new goal. And the fourth and last step is cross training. Instead of focusing on one type of exercise, build variety into your fitness program. So incorporate different variety of different activities. And use different muscle groups, and do not overload any one particular group. So next is the conservative treatment. As Professor Berkes discussed, the aims of treatment are to identify the cause of injury actually, and to reduce inflammation and promote healing and prevent complications. So the components of conservative treatment include avoidance of aggravating factors while maintaining fitness, and use of physical agents and electrotherapeutic modalities, and soft tissue techniques, and strengthening and rehabilitation, and medications such as NSAIDs. So my focus would be rehabilitation. So rehabilitation is very important in the management of overuse injuries, because it includes patient education, it includes supervised therapy for injured part, it includes the appropriate use of modalities like TENS, EMS, ointophoresis, phonophoresis, and it includes development of home exercise program, and it also includes the psychological factors. And rehabilitation focuses on relief of inflammation, restoration of normal joint arthrokinematics, and neuromuscular training. So quickly going through the phases of rehabilitation. So rehabilitation comprises of 3 phases, and it is defined by muscular action, either isometric, concentric, or eccentric, kinetic chain, either open or closed kinetic chain, range of motion, and exercise orientation. So phase number 1 aims to achieve active early mobilization, which provides mechanical and circulatory benefits. So it includes closed kinetic chain and the isometric muscle work. The phase 2 is aimed at improving functionality, intensity, and load. And it includes the progression of content in closed kinetic chain to open kinetic chain. And it is directed towards the concentric muscular work patterns. And the phase 3, it actually aims to reach the competition level intensity and exercise loading. And it is proposed under training conditions. So the main focus in the phase 3, which every rehab specialist or physiotherapy should take into consider, is that we perform activities in open chain, and the main exercises are the eccentric muscular work activities. So the main thing, the common thing in whole prevention and rehabilitation is exercise. So we can say that exercise is the best medicine to prevent and to rehabilitate the overuse injuries. That's all for our presentation. Thank you very much, and here we go for the question and answer session.
Question:
How to treat patients with hallux valgus? Can it done by just exercise? A question by Ethan.
Can I answer it?
Yes.
Yes. In the beginning phase, the hallux valgus can be treated by exercises, and the hallux valgus can be treated conservatively using exercise medicine in a very young patient. And I think that for the children, for the adolescent, young female, and especially active people and athletes, I try to do conservative treatment using exercise for a long time. The surgery only could be the last solution. And of course, we should use with the exercise different orthotics, different equipments, and of course, we can use actually a very special electrotherapy and massage therapy, and of course, we can use for the correction of the taping technique as well.
Vice answered.
Yeah.
Yeah, so and there is another question that why open chain exercise is not prescribed in the early phase. So in the early phase, we prescribe closed chain exercises because we are focusing on the concentric muscle work and not the eccentric muscle work. But in the late phases of this rehabilitation, because in the acute phase of the injury, we cannot go for eccentric activity. We only go for concentric, and in concentric we focus on the closed chain exercise. But in the later phases of the rehabilitation, we focus on the eccentric muscular activity, and that's why we prescribe the open chain exercises. Hope you got the answer.
Spinal operation for the kyphoscoliosis. I think that manual therapy and different exercise it could be very useful, and I think that the swimming maybe is the best therapy for this kind of patient. So we recommend for our patient the swimming, especially the freestyle and backstroke. Yes. Yeah. Of course, I think that the high intensity laser, shockwave, and far infrared rays, it's a good one for the special cases. And you asked me that which new machines are very useful. I think that the so-called anti-gravitation running equipment is a very good one for that treatment and for the rehabilitation of the physically active patient and for the athletes. So I could suggest this kind of the equipment to use for this kind of patient. Please.
The early low load and slow eccentric actually target elevated local.
What medium is usually for?
So we can. So another question from Sneha is that why we don't do this eccentric in the start. who are involved in different high impact exercise trainings, the elite athletes. So in elite athletes, this is the way that we start with the concentric in the early stages, and we end up with the eccentric activities in the late stages. But when we talk about the general population, the laymen who are not athletes and who are not so active in the lifestyle, then yes, Sneha, we can start with the low impact eccentric activities. Yes. So questions finished.
So thank you very much for your kind attention, and thank you very much for the opportunity to give our talk. And I hope that we meet next time in the Budapest next year. We are waiting everybody for our capital in Hungary, and we hope that next year the exercise medicine group will organize a very successful and very fruitful meeting conference in our nice city here in Budapest, in the University of Physical Education. Thank you very much again. Thank you. Okay. Thank you very much. No, they just try to speak. The next speaker will be Dr. Edgar Micheal from Philippines, and his talk speak on the ultimate healthy lifestyles checklist. Edgar Micheal is a very experienced orthopedic surgeon, and he's treated a lot of active and competitive athletes and active people. I think that he has a very big experience. I'm very excited to hear his presentation. Please, Edgar.
Hello everyone, I'm Edgar Michael Yew Fen. People call me Gar. I'm an orthopedic surgeon based in Manila, Philippines, with special interest in sports medicine. The title of my talk is The Ultimate Healthy Lifestyle Checklist, a sports doctor's perspective. This is peak form. It's a sports clinic. We try to handle everything an athlete needs under one roof, from injury management and prevention, even strength and conditioning. So we handle both the surgical and conservative treatment of injuries here. I guess the real challenge is finding out which of the new toys out there are truly beneficial for an athlete's progress. We have to do our research, but eventually we're able to produce individualized programs and protocols. This is Cardinal Santos Medical Center. This is in Manila. This had the first reported locally transmitted case of COVID-19 in the Philippines. One of my favorite authors is Dr. Atul Gawande. He likes to write about the challenges that doctors face in the modern world. In his best-selling book, The Checklist Manifesto, he tells us that no matter how intelligent or diligent an individual is, when confronted by a multitude of tasks, such as in a crisis situation, certain stages are easily missed. The solution is simple: a checklist, or a written guide that walks us through key steps in any complex procedure. For example, if you're in a plane that has to make an emergency landing, would you want the pilot to rely more on his experience or follow a checklist? Same thing with a bomb squad that's asked to disarm an explosive. But for the gentlemen in this group, think about the days leading up to your wedding. Your wife-to-be tells you to do a few things. Would you want to memorize this? Of course not. You make a list. That way you make sure you don't forget things and she doesn't kill you. Really, is there any mission more complicated than staying fit and healthy? Here then, ladies and gentlemen, is my version of the components of a healthy lifestyle. My worksheet has a dozen entries. To keep it simple and easy to remember, I divided it into the 4 E's, the 4 S's, and the 4 D's. The first E is for exercise. So you have both your cardio and your resistance training. So although it's best to work out in a gym or a fitness center, there are a lot of activities that you can actually do at home or at work. If you can fit it in, maybe 3 times a week should be pretty good already. So staying active helps boost your HDL or your good cholesterol while decreasing the unhealthy triglycerides. So this also helps decrease the incidence of hypertension, heart disease, stroke, type 2 diabetes, osteoarthritis, and osteoporosis. You notice that in some fitness centers, there are members who just have to work out every day. They feel sluggish or sickly whenever they miss a session. So these individuals are addicted to endorphins. These are the natural chemicals released by your body during workouts that interact with certain receptors in the brain and reduce your perception of pain. It also triggers a feel-good sensation, similar to that of morphine. And you notice that if you do regular exercise, you actually sleep better too. One of the things we noticed during the pandemic is that in order to stay fit, a lot of us had to be a little creative and make do with some of the things that we could see or have at home. No? So, of course, we have to be a little careful because since we're not used to the new routine, a lot of times some accidents may occur. Actually, there are a lot of things that you can download. A lot of things are online, all of these programs or things that you can do at home or in the office. You don't really need much space or much equipment. You just have to use your imagination and follow the principles, no? Get your heart rate up, work your muscles so that they get pumped, and make sure that you do it as many times as you can in a week. A few years ago, together with a few friends of mine, I developed the fitness quotient or the FQ test. It's very similar to an IQ test, but while the IQ test measures intelligence, the FQ test measures your fitness level. Just like an IQ test may be predictive of the kind of career, educational attainment, and even salary that one might have in the future, the fitness quotient test would be able to identify young individuals who have the potential to be super athletes. We measure the 10 components of fitness, meaning we have tests for strength, explosiveness, speed, agility, coordination, balance, flexibility, endurance, recovery, and mental. Our FQ test has 10 stations. So there are different tasks to highlight the different components of fitness. So one thing peculiar about this test is that all the activities
that the participants will do are adjusted to their height and their weight. I included a video so you can understand this a little better. So as you can see, every round, which lasts less than 30 minutes, you have 10 participants that go through 10 stations. Each activity or each station lasts 1 minute, and you have to go through all 10 stations with a 2-minute rest in between each station. So we start with a pre-test to determine the mean score per station. Then marshals are assigned to count and measure to determine your score, and are also there to adjust the activities according to your height and your weight. So points are added or subtracted depending on how far you are from the mean. So after finishing all 10 stations, you end up with a score. Obviously, the higher the score, the more fit you are. And the lower the score, the more you have to work on your fitness. So our categories go all the way from the elite level, all the way to the lowest level, which we call barely alive. The second E stands for eating habits. Previously, we were taught that to lose weight, all we had to do was eat less and exercise more. Obviously, that's easier said than done. It's actually very difficult to go through a rigorous exercise routine with decreased food intake. And furthermore, your body adjusts to the decreased calorie intake by slowing your metabolism down. So it's probably better to follow the following tips. First would be to stay clear of the bad carbohydrates, especially refined sugar. Then you also have white bread, white rice, pasta, and potatoes. Lessen also your intake of saturated fats. It's better to have light dinners and avoid binge eating. So it's better to have small, frequent feedings. Another book I enjoyed reading was Why We Get Fat and What to Do About It by Gary Taubes. It actually came at a very good time, very opportune moment. I was 30 pounds overweight, I'm diabetic, and I'm hypertensive. So going through the book and following some of the principles he discussed, I would say this book helped save my life. So having problems with my blood sugar, I run to my nutritionist and my cardiologist. So one of the controversial things in my mind then was the intake of fruits. So they told me all fruits are generally okay, just make sure you take them in moderation. They always tell me to be guided by the glycemic index. So the glycemic index is a numerical score that ranks carbohydrates based on their rate of conversion to glucose in the human body. So higher values cause a bigger rise in blood sugar, which is obviously not good, no? So to remember some of the fruits that have high glycemic index, I just follow these mnemonics, W, M, and G. So we try to lessen the intake of watermelon, mangoes, and grapes. I use this video to help my friends and patients remember what foodstuffs I recommend that are good to snack on when they get hungry. As you can see, there is a pass. And in the Philippines, when the ball goes in and barely touches the ring, we call it sulak. So pass stands for pears, apples, singkamas, and saba. Singkamas is a turnip, and saba is the local version of the cooking banana. Swak stands for seeds, walnuts, almonds, cashew, and kamote, which is a sweet potato. The third E is environment. So the perfect living situation has no pollution, no traffic, no excessive heat, and no excessive humidity. It has just enough sunlight and is quiet. So I guess all of us city dwellers are doomed. The fourth E stands for enjoyment. So the important categories here are your family, friends, and work. I guess the coronavirus forced us to spend more time with our loved ones than we're used to. I don't know about you, but I'm actually having a fabulous time. So we have a lot of meals together, we watch television together, and even drink alcohol together. So we should also surround ourselves with friends who make us happy and who we enjoy hanging around with. Remember the saying, if you enjoy your career, you never have to work for the rest of your life. You actually wake up excited when it's Monday. Another chance to do something good, something great. Another thing that happened during the pandemic, I was able to combine two things: gardening, which I was never good at, and my career, which is orthopedic surgery. My daughter assigned me to care for this drooping, dying plant. I did the best that I could. I think I did okay. What do you think? Now let's go to the four S's. The first one is sleep. 40 winks play an important role in your health. It is involved in healing and repair of your heart, blood vessels, and muscles. Ongoing sleep deficiency is linked to an increased risk of heart and kidney disease, hypertension, diabetes, and stroke. Furthermore, when you are in deep slumber, you cannot overeat, smoke, or drink alcohol. An added bonus, you also circumvent stress. We will discuss this later. Everyone emphasizes getting at least 8 hours sleep, but have you realized that the older you get, the less you are able to sleep continuously? So just get as much rest as you can, whether at home, in the car, or maybe even at work. But of course, during break time only. The second S is stress reduction. During stressful situations, two hormones are released into your bloodstream: adrenaline and cortisol. Adrenaline increases your heart rate and blood pressure and raises glucose and lipid levels. Cortisol, meanwhile, enhances your brain's use of glucose while altering functions that are not essential during a stressful situation, like the digestive and reproductive systems. Once the threat has passed, both levels drop and your body goes back to normal. If you are constantly under pressure, the overexposure to cortisol can lead to depression, memory impairment, sleep disorder, heart disease, digestive problems, weight gain, and even sexual dysfunction. There will always be problems, but it's how you respond to these situations that will determine how your life will be. The third S stands for supplements. Please limit it to vitamins and minerals, maybe stem cell enhancers. During the pandemic, I guess there's extra emphasis now on vitamin C and zinc. Enough of the tiger bone, bear gallbladder, rhino horn, shark fin, and snake blood crap. Animals are being hunted to extinction because of the idiots behind the trade and the bozos who still believe in their medicinal properties. The final S is spirituality. Even if we're doctors, deep down inside, we still have to believe that there is a supreme being and a power greater than us. We have to pray often and learn to appreciate nature. Just knowing that there is someone up there should have a calming effect on us, and we all know what stress reduction can do to good old cortisol. In March, during the early weeks of the lockdown in the Philippines, one of the early casualties was a good friend of mine. He was an anesthesiologist who passed away in the line of duty. I knew then I may not be a pulmonologist or an infectious disease specialist, but I thought I had to do my share. So on April 1, we opened the KKK Center. KKK stands for Kalinga Contra Corona. Kalinga in Filipino stands for Giving Refuge or Support. This project was the first of its kind. It linked a private enterprise with a local government unit in setting up a quarantine facility. Soon after, we set up another quarantine facility for Pasig, another key city in Metro Manila. We all do regular talks and seminars to coaches and trainers. Everybody seems to want to know, how do we achieve fitness? So other than the 4 E's and the 4 S's, you also need the 4 D's. The first D stands for DNA, or your genes. I'm a firm believer that athletes can be made. Proper training could make a subpar individual average, a so-so performer decent, or a respectable player very good. But the truly elite ones, the super athletes, they are born that way, and that takes genes. Accept it. They have it, we don't. The second D is desire. A lot of times, there has to be a turning point in your life that will give you the impetus to do something for your health. Too often, it has to be a dramatic event. A close friend or a relative passes away. You suffer from a stroke or a heart attack. Or the most dreaded example, you go to your favorite clothing store and nothing fits. In my case, it was my mother telling me a few weeks before she died that she hoped I would stop smoking. I quit many times before, but would always go back to the habit after a few months, and my excuse was always stress. When you do it for someone who matters to you, there is a bigger chance that you will stick to it. Shortly after that, while staring at my horrible blood tests and weighing myself, I caught myself thinking about who will be speaking during my eulogy when my time comes. That, for me, was the signal. The third D is discipline. So now you know what to do. Now you've actually started it. Now the question is, can you maintain it? It's one thing to be cognizant of what has to be accomplished, quite another to actually make it happen. But the real test is actually, can you keep at it? Challenge accepted? The fourth D is education or education. The specialty of sports medicine is continually evolving. New studies are constantly churned out. It is my responsibility to always keep abreast on what is new and to know what is bogus. So do your share. Read books and magazines, attend lectures, consult experts, talk to friends, and try different things and routines. So in summary, this is the ultimate healthy lifestyle checklist. How many checks do you have? Thank you very much for your kind attention.
That ends my talk. If there are any questions, I'll gladly take them now.
There's a question here. How do you set a progression checklist to ensure I have improvement on my healthy lifestyle checklist? I guess the key, especially when we do the fitness quotient test, we actually do the tests at intervals, maybe 3 to 6 months apart, and see if your scores will improve. No? I guess for the total checklist, there are some things that you can't really change, especially the DNA. It comes with your genes. So there are things that you can do about the other things, and like reducing stress and eating right and exercising. So I think overall, it's just a matter of knowing what are the things that you have to do so that you can improve. I think the whole goal is to try to do what you can to stay fit, stay healthy, and pass on the good news to the other people. There's a question: what would you like to say to anyone who says they have no time to exercise? I have patients who tell me that, no, they're CEOs of their companies telling me, I'm too busy, I have to do this, do that, and I have no time really to take care of myself, no, and to exercise. I said, okay, that's very good. So at least you'll probably make a lot of money to leave to your kids because you probably won't live long enough to enjoy your money anyway. I think as you get older, you realize that it's really the quality of life that matters rather than how long you live, no? So I guess to live longer is also dependent on how well you take care of yourself. It's the fitness quotient published. I've been asked to give this talk several times. We're in the process of publishing. The problem initially was to set the initial scores during the pre-test. So once we've set that, we started using it on high school students and then on people working out, starting a gym program, and then we do the test again for them to see if they will improve. So I think there's some promise on it, but it is financially quite difficult to manage. So what's been happening, the city mayors have been coordinating to use it for their use for their public schools, just to see if there are budding athletes out there that might have a good chance of doing something special in the future. What are the fruits and vegetables for improving immunity? I guess obviously the nutritionists are in a better position to answer these, but with my little research, I guess sugar is the thing that we worry most about when we take fruits. So doing it in moderation, I think all the other things like the vitamins and all the other antioxidants are worth taking in. No? So vegetables, I have nothing really against that. Obviously, as you try to get healthier, the salads and all of these vegetables come into play. No, I guess better to be a little more conscious about not overcooking vegetables, because that's where a lot of the vitamins and the minerals get lost. What is your opinion about the trend of obsession over the quantity of proteins? I guess this is pretty much like the keto diet. I've never been a huge fan of pure protein. Obviously, if you're going to cut down on the harmful carbohydrates, the proteins tend to be increased. But I don't think we have to be too obsessed in feeding ourselves only with proteins. Other things will go and have problems, like your gallbladder, your kidneys. And I think one of the studies that they actually showed before that an overemphasis on a high protein diet actually led to a shorter life in the midterm, no? The midterm results. So I've always been very careful about calling it a keto diet or a high protein diet or an exclusively protein diet. So fitness quotient only suitable for athletes. Actually, the reason it becomes important now is because it's a test for fitness. It's okay for everybody, from the couch potatoes all the way to the elite athletes. Maybe you will see where you rank in the general population after you take the test. And your goal, if you're let's say a couch potato who's been never exercising your whole life, then you see the scores get really bad, maybe it will trigger something to get you to do what it takes just to be an average athlete, no? Or an average weekend exerciser. Then if you're an average athlete from the scores, even if you're not really exercising that hard, then you know that you have the potential for something big. So I think it's suitable for everybody. I think the end goal, at least maybe for Philippine sports, is to be able to pick up maybe from the poorer population, who are those with potential to be something else, no, in society. Then you mentioned supplements. I'm not a huge fan of always prescribing supplements. Multivitamins are always good for me. I'm not one to support one group over the other, but obviously, if you do your own research and not listen only to marketing, I'm sure you will be able to pick one that's best suited for you. But I don't think going for good supplements will replace the other components still, no? You still have to exercise, you have to eat properly, you have to sleep properly, and try to minimize stress, no? So it's really, I guess, as it says, no, it's a supplement. You add more to what you're already doing. So if you're doing everything properly, then you add supplements. I guess that gives you some extra points for your checklist. I think that was the last question. Thank you very much. Very nice to see you again, Professor Istvan.
Me too. It was a very nice lecture again.
Yeah, you're looking younger every time I see you, sir.
No. You look good. Okay. It was a very nice lecture again, and it was a very good discussion. I congratulate you. And I think that we meet again in Budapest soon. Okay, and next speaker is Miss Yew Su Fen from Malaysia. Her talk will be Battle of the Bulge Obesity. It's stolen the pelvic floor. Please, Yew Su Fen, start your lecture.
Hello, I'm Su Fen, a physiotherapist. First of all, I would like to thank the organizing committee of the BUCEM 2020 for giving me this opportunity to present my topic. So the topic for me today is Battle of the Bulge, and you know what the Battle of the Bulge means? That is obesity, and it's toll on the pelvic floor. Okay, let's look at this research that is done and presented in the BJOG, obesity and urinary incontinence in women. As you can see, obesity here is defined as women more than 20% of the average body weight in comparing the height and weight and age. And this shows that is 368 incontinent women, of which 232, that is 63%, were diagnosed as having genuine stress incontinence, and 136, that is 27%, as having detrusor instability. That means a great number of obese women actually present with incontinence problem. Now the next one is obesity. This is an epidemiology study, and it's documented that overweight and obese women actually have a greater risk factor for incontinence. Another meta-analysis done and published in Obesity Review Australia 2018, being overweight was associated with 1/3 increase in the risk of urinary incontinence, while the risk was doubled in women with obese. That means the bigger you are or the more obese you are, the chances is greater that you will get urinary incontinence. So overweight and obesity are strong predictors of urinary incontinence. This is presented by Tomohiro Matsuo in Japan during the International Continence Society 2018 annual meeting. And he presented that the ratio of visceral fat volume to total abdominal fat volume is an independent risk factor for overactive bladder. Again, obesity and bladder. So it is found that every 5 units of increase in body mass index, that's your BMI, there will be about 20 to 70% increase in urinary incontinence. That is very, very high. So the more obese you are, the greater the chances of you having pelvic floor problem. The function of the pelvic floor, what is it? Number one, very important, is it provides support to our bladder, the uterus, rectum, and all the abdominal organs against gravity and added downward pressure. Added downward pressure means increased intra-abdominal pressure, like for example, when you're lifting something heavy. And the next one is sexual function and give tone to the vaginal floor muscles. We know that women with very weak vaginal floor muscles actually have a difficult problem getting aroused and achieving orgasm. So we found that actually women with strong pelvic floor muscles gets orgasm more easily. Next one is stability. So if your pelvic floor, which is a component of core, if it is not strong, actually it does not stabilize our pelvic and lower back, and this will give rise to people with more backache. The next one is sphincteric function. That means it is used for defecation and urination. Like for example, being able to relax completely, to defecate and urinate, and to contract in cases where you do not need to urinate, like for example, when you are sneezing. The next one is to maintain the anorectal angle. So you will find that there are a lot of other functions which is important, role of the pelvic floor, and this is just 5 that I would like to mention. Now, the pelvic floor muscle actually acts like a hammock. It is a funnel-shaped muscle that stretches like a hammock running from the pubic bone to the tailbone and are made up of two distinct layers, that is the superficial layer and the deep layer. So this is the muscles that you can see here. Now the levator ani, which is composed of the pubococcygeus muscle, the puborectalis, iliococcygeus, and these are very important muscles in maintaining continence in both men and women. Men do experience incontinence too, especially post-prostate cancer management, like for example in TURB. And these muscles, if they are weakened in one way or another, will eventually cause urinary incontinence and sometimes defecation. So how does obesity affect the pelvic floor? Now the clinical reasoning is that when you carry excess weight, especially in the abdominal area, it increases the intra-abdominal pressure and intravesical pressure. Now this increase in the intra-abdominal weight and pressure can have a long-lasting and damaging effect on the pelvic floor by weakening the pelvic floor, the urethral structures, and cause nerve damage, therefore making bladder leaks and causes dysfunction of the pelvic floor. So if you look at this diagram, now when the pelvic floor is toned, you can see that it is stretched. But if the pelvic floor is very weak, then it becomes a droopy hammock. So this is an example, like for example, if you have normal abdominal visceral fat, that is the diagram on the right side, the pelvic floor is not overstretched. Whereas the other picture, you can see that you have excess abdominal fat, excess visceral fat, and this provides an added downward pressure on the pelvic floor, thereby causing the pelvic floor to sag and weaken. So the pelvic floor can be made weaker by several reasons, like for example, overweight and obese. Okay, and patients not keeping active, for example, when you're getting older, you're not exercising, your pelvic floor can get deconditioned. The third one is multiple pregnancies, because each time there is a pregnancy, a lot of extra weight is added onto the pelvic floor, right? The next one is chronic constipation, where you go into the toilet and you squat and you strain for minutes, you know, and constantly, if you are doing this day in and day out, it will eventually cause the pelvic floor to be weak. And the other one is lifting weight. If it is not lifted in the correct way, it is again an added increase in intra-abdominal pressure, which will actually weaken the pelvic floor. And the other one is chronic cough. Constant chronic cough increases intra-abdominal pressure, stretches the pelvic floor, and causes weakening of the pelvic floor. Now, what happens to a weakened pelvic floor? It can give rise to several problems, like for example, urinary incontinence, which is the most common, and it is defined by ICS as an involuntary leakage of urine on effort or exertion or on sneezing and coughing, okay, up to 20 to 70%. So if you look at the picture, if you have a weak bladder, the first one, it cannot control the muscles properly, constrict the muscles properly, and therefore urine will leak. Now on the third one, look at the muscles, it becomes very strong, and therefore you are able to control your urine even though if your bladder is full. Next one is pelvic organ prolapse, okay? It is a protrusion of one or more pelvic organs. So pelvic organ prolapse not necessarily refers only to the uterus. It can be a wart prolapse, it can be a urethrocoel, it can be a cystocoel, it could be an enterocoel and even a rectocoel. So all the structures that is around the vaginal area actually can prolapse when the pelvic floor is weak. And the third one is fecal incontinence. That means you either have incontinence of gas which is the most frequent type, or you have incontinence of liquid. That means you feel like passing the gas, but you are not able to contract at all because of the weak pelvic floor. The fourth one is instability. That means you have a weak core. It will lead to pelvic instability, lead to backache, poor posture and balance, resulting from a multitude of musculoskeletal problems. The fifth one is sexual function. Now, the higher the BMI, the lower the female function index score. Now, this score shows that women with very high BMI or who are obese, actually their sexual function index score is very low. Okay, so the more obese the female is, the greater is the likelihood of the female having sexual dysfunction. Now, how can we manage weak pelvic floor, or what is the treatment for weak pelvic floor muscles and dysfunction? Okay. Now, as you can see here, number one is in asterisk. That means it is the most important of all the things that we are going to do for this patient, or we're going to provide for the patient. You find that if you continue to be obese, there is no need to strengthen the core muscles or the pelvic floor, because the pelvic floor will constantly be stressed by the overweight. So it's very important that the first one is patients should actually do regular exercise and manage a healthy lifestyle, like eating healthy, so that they can reduce the body weight. And once the body weight is reduced, automatically you will find that the pelvic floor muscles actually becomes stronger, because there is no added job or added weight for the pelvic floor to carry. The next one is we have to exercise to strengthen the core muscles. And the specific exercise that is to be done for pelvic floor muscles, such as Kegels, and there are a lot of other things that we can use to strengthen the pelvic floor, such as using adjuncts. So if you look at this picture, the diaphragm on the top, the abdominal wall that is surrounding the trunk, and the pelvic floor, actually these are the core muscles that actually maintain the strength of our core. Now, if the diaphragm is weak, that means one component is weak. If the pelvic floor is weak, then the other component is weak. So we need to strengthen not only the abdominal walls. We always think that the core means you strengthen the abdominal wall, but we forget the diaphragm and the pelvic floor. So we have to stress on the pelvic floor as a part of our core muscles. So if you look at this picture, we have the diaphragm on the top and the pelvic floor muscles on the bottom. Now, the abdominal walls, respiratory diaphragm and pelvic diaphragm forms the functional cylinder. And these muscles actually protect the spine and pelvis during any mechanical loading and exercise. So if the pelvic floor diaphragm is weak, then the entire mechanism is affected. So when we do core strengthening, we must remember we must not leave out the pelvic diaphragm. So when we have increased in intra-abdominal pressure, that means when we want to cough, what happens is that we will contract all these muscles so that it does not have an added pressure on the pelvic diaphragm. So when we have a poor or weak pelvic floor and there is an increase in abdominal pressure, then the pressure will go down to the bottom. That means it goes to your pelvic floor, and that's why you leak. So the exercises for the pelvic floor muscles, we know that the pelvic floor is a complex web of muscles, and it requires several types of exercises to regain its muscle tone and strength. So if the pelvic floor is tight, it does not mean that tight muscles is strong. It can be weak, okay? Because the tight muscles is not working. Now, if the pelvic floor is overworked, for example, if it is constantly supporting a heavy load, the best example is an obese patient with a huge abdomen, okay? Or it is stretched and it becomes very weak. Multiple pregnancies, constantly carrying heavy objects the wrong way, and all these will lead to weak pelvic floor. So if we look at this We know that Kegel exercise is very popular. The whole world knows about Kegel. Okay, Kegel was discovered in 1948 by an obstetric doctor, and it is named after him. That's why it's called Kegel exercise. So the Kegel is an exercise designed to help to strengthen the pelvic floor through muscles contraction and to prevent problems such as incontinence and prolapsed uterus. Okay. So these are the exercises that can be done to improve the strength and the tone and the feeling in the pelvic floor when it is done correctly. So we need to know that there are two types of fibers in the pelvic floor muscles. For example, type 1 and type 2. Type 1 is actually the slow twitch fibers, and type 2 is the fast twitch fibers. Now, type 2 makes up 70% of the pelvic floor muscles. So a lot of these muscles need to be strengthened to maintain continence, okay? So pelvic floor muscles are the only transverse load bearing muscles in our body, and that's why we have to concentrate on the pelvic floor. Now, how do we do Kegel exercise? Number one, very important, is to find the right muscles. There are many patients who come to us and they don't even know how to identify the pelvic floor. They cannot contract the correct muscles, okay? So to identify the pelvic floor muscles, you can try midstream stopping. That means you urinate and then you try to squeeze the muscles. If you are able to do it, then you must feel that muscles, remember that muscles, and when you do your pelvic floor, you have to remember what you have done during midstream stopping. And the other one is, we call it digital sensation that you feel when you insert your finger inside. So what we do is we get the patients to wash the fingers, insert into the vagina, try and squeeze the fingers, then remember that feeling, remember which is the muscle that is functioning, and when you do your Kegels, you have to go back to these muscles that you have identified. So to do the Kegels, what we teach, a very simple one, is imagine there is a 50-cent coin at the entrance of your vagina. Now what you have to do is you tighten your pelvic floor or pelvic floor muscles, and you try to lift the coin up from where you are sitting, and you hold it for 3 seconds and relax it for an equal number of seconds. Now the 50-cent coin acts as a stimulus, because your mind then will concentrate on the 50-cent coin and urging your pelvic floor or the muscles at the pelvic entrance to squeeze and then to suck up the 50-cent coin. Okay, that is one of the best way to identify and do the correct Kegel. Okay, maintain focus is very important, because you are not supposed to squeeze your buttocks muscles and your thighs muscles, because then you are not actually correctly doing your Kegel exercise. Okay. Now, how long do we have to do? Now, there is actually no limit on the number of times that you can do, but you can do it as a minimum of 3 sets of 10 to 15 repetitions a day, okay? And then you continue to progress as the muscle gets stronger. And we know that the golden rule for increasing exercises is try to target 10% increase from the norm that you are doing. Okay, many doctors actually advise patients to perform Kegel exercise while emptying the bladder, okay? And it has been a practice for some time, but actually when we do this too many times and execute wrongly, we can lead to incomplete emptying of the bladder, which will cause an increase in the risk of urinary tract infection. So nowadays we actually tell patients that you cannot do too many times midstream stopping, and it's important that you do your Kegel exercise correctly. Okay, now adjuncts can be used to provide tactile stimulation, because we as humans, just listening is not enough. We need to see. Just seeing is not enough. We need to touch, okay? Because these are the things will actually enhance our learning. So one can strengthen the pelvic floor by using finger stimulation, like I mentioned just now. Insert the 2 clean fingers inside and try to squeeze the finger to a number of seconds of hold and then relax. Okay, next one we can try is to use the vaginal cone or a perineometer or a vaginal nanometer. Now this acts as an external stimulus which will help for the patients to actually feel where the pelvic floor is and squeeze it correctly. Okay, the vaginal cone is a weighted device that is inserted into the vagina, and the weighted cone will provide a tactile stimulus to get the correct muscles to contract. Okay, why am I showing you this picture of the king and the concubine? Now the king has many concubines, so much so that the concubine may not get to see the king even once a year. So what do you think they need to do? Not only getting beautiful physically, because this does not keep the concubine. So what keeps the this does not keep the king. So what do you think will make the king comes to the concubine and keep on coming to the concubine? So if you look at this slide, now Fanny Fen says, the way to a man's heart is through his stomach. But this is not true anymore because good food is available at every corner of the street and 24 hours a day. So your husband is not coming back to you for good food. So what is the thing that will keep your husband coming home every day? Now, I would like to change this phrase to, the way to a man's heart is how strong you can keep on grip on the thing which is 10 inches below the stomach. So this new phrase is showing you that a powerful pelvic floor muscles is very important component of our sexual life. So many years ago, in order to maintain their pelvic strength or to strengthen their pelvic floor, what does the concubine do? They go to the streams, pick pebbles from the stream and insert it into the vagina and try to keep the pebbles in the vagina. And nowadays we have medical devices which actually is exactly like the pebbles, which is inserted into the vagina, and you contract the vaginal muscles to keep the pebbles inside these objects inside. So you can use semi-precious stone, like for example, you have a rose quartz pebbles, you have tiger eye pebbles, or you have medical devices which is available called the vaginal cones. And if you go to a physiotherapist, they will show you the correct way to insert the vaginal cone and how to exercise with the vaginal cone. So 3,000 years ago, pelvic floor, they use pebbles. Now we use very high-tech devices. Now this is the picture of a female pneumatic pelvic floor trainer. Now you can use this gadget to help strengthen your pelvic floor muscles, improve bladder leaks and incontinence, and also it can be used to improve sexual life quality and satisfaction. Now, when you insert this pneumatic head into the vagina and squeeze the vagina, you can actually see the recording or the reading of how much pressure you are squeezing. Now, this stimulus will actually encourage you to squeeze the correct muscles, and also you can gauge how much or how strong is your pelvic floor. Now, I would like to put this as my take-home message. Obesity has become an important public health problem worldwide. Now, the prevalence of obesity increases so much so that, and so does the burden of its associated comorbidities, such as heart diseases, diabetic, hypertension, a lot of other problems. And one will not imagine that obesity will have its toll on the pelvic floor muscles as well. That means our shy muscles. Now, as long as the problem of obesity is not addressed, all the Kegel muscles you exercise will not make the mid-shy muscles stronger, because these pelvic floor muscles will continue to carry the burden of the overload, and it will continue to be overstretched and constantly being weakened. So even if you exercise, you're not going to get stronger because you do not remove the problem, and the problem is obesity. So we know that obesity up to 70% eventually will end up with having stress urinary incontinence. So it is very important that we address this issue. So folks, start exercising, get slim, get fit, and get healthy.
Thank you very much for the questions. First of all, Ms. Wang, what exercises is good for reducing the anterior pelvic tilt? Okay, we know that the abdominal muscles is actually one of the very important component in maintaining the strength of the pelvic girdle, right? Together with, like I say, the pelvic girdle needs strong core muscles, and that is a very important one is your pelvic floor muscles, and also your abdominal muscles. And we know that the abdominal muscles is not just one group of muscles. We have several groups like the transverse abdominis, which is also very important, besides the rectus abdominis. Then you have muscles that actually is your back muscles, right? Because you need a balance between the front and the back to maintain the pelvic tilt. So if one of the component is very weak, then you find that the tilt will go in a different direction. So if you have an anterior tilt, then you have to correct it so that it goes into the normal tilt, okay? So you have the back muscles and you have the abdominal muscles. So when it is an anterior tilt, we know that the abdominal muscles are not strong, so we have to strengthen the abdominal muscles. Okay, Ethan asked, which pelvic muscle group would you like to strengthen to provide a stable hip? Okay, so as we know that just now I already mentioned in my talk that the core muscles is not just the abdominals or the back muscles. We also have to remember that at the top, at the bottom, you have two other diaphragms, because when you have a disruption in one component, then it will disrupt the general core. So for the pelvic muscles to be strong, we should not only concentrate on the abdominals and the back muscles, the extensors of the back, the rectus, what do you call it, the multifidus and all this. Okay, we still need to strengthen the pelvic floor, because if the pelvic floor is very weak, then the pressure changes its direction, and therefore it will disrupt the pelvic stability. So if you remember the picture of the cylinder, then when we talk about strengthening the core muscles to maintain pelvic stability, then we have to remember that if the patient have very strong back and abdominal muscles, but they have weak pelvic floor muscles, it will disrupt the stability of the pelvis as well. So I hope that this answers your question. Okay, Michael asked, what is the most suitable core muscles exercise for patients with extremely high BMI? Okay, again, having a high BMI actually does not generally tell you which muscle is weak, because there are people who have a very huge abdomen or trunk, and there are people who have very huge arms and thighs. So their BMI contribution actually do not necessarily come from one part, but it can be from the limbs as well, okay? So for me, I would think that when you have excess fat, that means your muscles hypertrophy, okay? That means there is not much muscle, but more fat. So what we should do is, the most important thing is we still have to reduce our obesity, because if we try to strengthen our core muscles, but all the time we are actually defeating it because of our excessive weight, okay? So we can strengthen our core muscles, but at the same time, we need to reduce our fat. That means we have to do general exercises to burn the fat first, then only we go to strengthening exercise of the core muscles. If you continue to strengthen the core muscles, but the obese, the excess weight defeats your purpose, okay? So I feel that what is important is the general weight reduction exercise should be done. And it can be just walking constantly, like we practice 10,000 steps a day. You can do aerobics exercise, swimming, and then maintain a healthy diet reduce intake of substances that can actually add on to your weight. And then we go on to strengthen your core muscles, okay? So what sort of exercise can be done for male erectile dysfunction? Okay, now this question is very general because we do not know what is the cause of male erectile dysfunction. We have to know the cause first. Now, is obesity one of the reasons? It could be, right? Then it could be stress. It could be many other reasons that causes erectile dysfunction. But is there any specific exercise for erectile dysfunction under the continence topic? I think there is no particular exercise that we can do unless we know that it is due to weak pelvic floor muscles, which actually cannot contract properly, okay? So we do teach male incontinence, right? Male patients for their incontinence. But actually as a physiotherapist, we do not have or teach patients to solve their erectile problems. Because like I say, the erectile problems, we have to find out what is the cause first. And I think the most suitable person will be to refer to a urologist. And if the urologist think that pelvic floor exercise is necessary, then it will be our job to strengthen the pelvic floor. All right. Okay, what is the mechanism linkage between pelvic floor muscles and orgasm? Okay, it's a very, very important and very interesting question. Now, I was trained by Netherlands, a Dutch physiotherapist, and she is also a sex therapist as well. And she says that pelvic floor is very important, play a very important in orgasm. Now, if the muscles is very weak, okay, the sensation or the stimulation of the pelvic floor or the muscles is definitely not that. For example, I have got a patient who told me that her husband says that when having sex with her is like a straw stirring in a cup. This shows that the pelvic is extremely weak and there is no grip or no sensation offered by the female. Therefore, it's important to strengthen the pelvic floor because the pelvic floor, the more is the tactile stimulus, and the more the patient or the female is able to feel or to get that sensation. Definitely arousal is easier, and the patient will therefore be able to achieve a more satisfying orgasm. I don't know whether I have much time. I think this is the last one, right? Okay, this is the last question, and I hope I've answered your questions.
Okay. Thank you, Miss Su Fen. It was a really nice and interesting talk and discussion also. Thank you very much again for your lecture. We should go further. Next speaker is Dr. Mahmoud Othman from Syria. He's a good friend of us. It's an old friend of us. He was studying in Hungary some years ago in the University of Physical Education. His presentation will be on impact of simplified exercise program on weight reduction and quality of life of overweight and obese inactive diabetes mellitus 2 patients with and without non-specific chronic low back pain. Dr. Othman, are you here? Can you hear me? Hello, Mahmoud.
Mr. Chairman, dear professors, doctors, students, ladies and gentlemen, Extensively well documented and far-reaching researches have pointed out that regular practice of physical activity and involvement in systematic exercise programs are an important factors in the prevention and or treatment progress of non-communicable diseases, and definitely play a vital role in weight reduction and body composition modifications. In addition, it also provides physical and psychological benefits to individuals in various age groups. On the other hand, regular physical activity and participation in exercise programs also associated with several aspects of quality of life, and this relationship has been consistently reported in the related literature. Therefore, our research idea, and at the same time its title, was Impact of a Simplified Exercise Program on Weight Reduction and Quality of Life of Overweight and Obese Inactive Diabetes Mellitus Type 2 patients with and without non-specific chronic lower back pain. The aim of the present study was to first examine the potential effects of planned exercise program on weight reduction and quality of life of diabetes mellitus type 2 obese and overweight patients, and second, to compare these variables between diabetes mellitus patients group and diabetes mellitus patient with lower back pain group. About the subjects and methods applied in the current research. First, starting with the subjects, the secondary current data was derived from a multidimensional survey which is intended for investigating patients living with non-communicable diseases from various age groups and for both sexes. But for the present study, we select those patients who had one communicable disease represented by diabetes mellitus type 2, and that the statistical analysis was confined on them only. As it demonstrated in graph 1, our sample was consisted of 102 diabetes mellitus type 2 patients with 35.5 years mean age. Of those, 46 were with diabetes mellitus only. This will be the diabetic group, and 56 had non-specific lower back pain beside the diabetes, and this will be the diabetic group with lower back pain. In the diabetic group, there were 21 males and 25 females, and in the diabetic group with lower back pain, there were 24 males and 32 females. All of them were from South Syria, namely from 4 governorates, the capital city Damascus, and from Dar'a, Quneitra, and Suwaida governorates. To discriminate the specific lower back pain from non-specific lower back pain, the non-specific lower back pain reveals that there is no anatomical pathological origin for their pain, and this was evaluated according to their existing medical records. And, second, for exercise program. From table 1, we can see that our planned exercise program was predominantly constructed of endurance, strength, and stretching sections. All of the 3 sections were built in a progressive manner. Endurance unit starts from slow tempo to fast one, and from walking to running. Strength units from static exercises with less sets and repetitions to dynamic and mixed exercises with more sets and repetitions. Stretching units also started with static stretching exercises and proceeded forward to dynamic and proprioceptive neuromuscular facility (PNF) exercises. However, the exercise program had persisted for 6 weeks, 3 sessions per week, and for a session lasting 70-90 minutes. After warming up, every session was started with endurance, followed by strength, and ended by stretching loads. And lastly, the quality of life scale. In the current research, quality of life was evaluated by applying the abbreviated Arabic version of the World Health Organization scale, WHO Quality of Life Brief Arabic. The questionnaire contains 26 questions and covers 4 quality of life domains: physical domain, psychological domain, environment domain, and social relations domain. The results and discussions of the current research. First, we display weight and body mass index results. From graph 2, we can conclude that in the baseline or pre-intervention data, there were significant differences in body weight between the two groups, diabetic and diabetic with lower back pain. And these differences continue to exist in post-intervention likewise. On the other hand, and according to post-intervention data, body weight had reduced significantly from 73.77 to 68.13 kilogram in diabetic group, and from 81.34 to 75.81 in diabetic with lower back pain group. Same trend can be detected in body mass index, where significant differences were existed between the two groups in the baseline data, and at the same time, values had decreased significantly in post-intervention from 27.11 to 24.42 kilogram per square meter in diabetic group, and from 29.69 to 26.18 kilogram per square meter in diabetic group with lower back pain. These results are powerfully strengthening the intense outcomes of previous studies and researches, which comprehensively highlighted that participation in well-planned exercise programs definitely lead to weight reduction and weight regulation. But when we consider these numbers and the significant differences between them, a rational question may emerge. Why diabetic group had a significantly better results than diabetic group in lower back pain, although both groups had completed the formulated exercise program concurrently and had performed the exercises in the 3 sections jointly. To demonstrate weight reduction in kilogram for both groups and for the entire sample after completing the exercise program, where weight reduction was 7.69 kilogram for the entire sample and 8.62 kilogram for the diabetic group and 6.55 kilogram for diabetic group with lower back pain. This means a significant difference between the two groups. This difference, which exceeded the 2 kilograms. According to the interviews with the patients, the main reason of this difference is firstly the predisposition of patients with lower back pain, where fear of movement was the dominant concept in their daily life. This means their functional experiences indicated for them that exercise, physical activity, or movement in general or as conventional concept are certainly associated with pain. And this maybe was the foundation why they are principally inactive. Another explanation may be the percentages of overweight and obese patients and their distribution between the two groups. From graph 3, which represents pre-intervention overweight and obese percentages, we can discern that obese patient in diabetic with lower back pain group had greater percentage than in diabetic group. By numbers, 46.43% in diabetic with lower back pain group as opposed to 32.61% in diabetic group. Yet, the higher percentage of obese patients support the fact that obesity undoubtedly reflects the difficulty of performing the exercises in the approved manner, competently and efficiently. And therefore, the value of weight reduction in diabetic with lower back pain group is lesser than that in diabetic group, despite that the two groups had definitely achieved the main goal presented by body weight reduction. This result became more well defined by examining the graph 4. Graph 4 represents post-intervention overweight and obese percentages, where we can distinguish a new column in addition to the two obese and overweight column. This column represents the normal weight patients, those patients who were able to transform their body weight from overweight or obese to normal weight. However, as disclosed obviously in body weight reduction, here also there were differences between the two groups, where 43.48% of the patients in the diabetic group became having normal body weight, compared to only 25% of diabetic with lower back pain group. To make these differences in body weight transformation more clear, graph 5 presents body weight of the entire sample and of the two groups in pre and post intervention. Shown in the graph 5, percentage value of patient of overweight had changed from 59.80% to 50.98% and from 67.39% to 39.19% and from 53.57% to 60.71%, and alongside the obesity portion from 40.20% to 15.69% and from 32.61% to 17.39% and from 46.43% to 14.29% for anti-simple, diabetic group, lower back pain, respectively. The remaining percentage values had changed to normal weight, namely 1/3 of the entire sample, 33.33%, 43.48% of diabetic group, and 25% for diabetic group with lower back pain became normal weight. The high percentage value, 60.71% in post-intervention for overweight patient in the diabetic group with lower back pain, comparing with 53.57% in pre-intervention, can be explained by the high volume of obese patients from pre-intervention who became overweight, comparing with obese in post-intervention. By numbers, the 46 14.43% of obese patients in pre-intervention had changed to 14.29% in post-intervention. This value can be acknowledged by viewing the table 3, which demonstrates the transformation from one category to another, overweight to normal and obese to overweight, and who remain in the same category, overweight or obese. As it presented in the table, no obese patient transfers to normal weight category. Consequently, this result simply means that body weight transformation of all of the obese patients was from obese category to overweight category. Then, by simple calculation, 46.43% in pre-intervention minus 14.29% in post-intervention, this equal to 32.14%. Then, 32.14% of obese patients had passed through transformation to lower body weight category, namely to overweight category only, and no one have passed to normal weight. This attention-grabbing result in the table 3, that no patient in obese category became normal weight, can be enlightened by the fact that transferring from overweight to normal weight category is less complicated and needs directly single step only, as presented in graph 6. But transformation from obesity to normal weight needs longer way, 2 steps, because it must pass through overweight category. And it unquestionably requires more challenging processes. Now, the second measure of our research was the quality of life. Initially, we compared the quality of life of the two groups before the launch of the exercise program. As it appears in the graph 7, the statistical analysis discloses that there were significant differences between the two groups in pre-intervention results on the quality of life whole scale and subscales domains. The feeblest results was for the physical domain, 55.4 for diabetic group and 51.1 for diabetic with lower back pain group. And the strongest convincing result was for the environment domain, 66.8 for diabetic group and 61.5 for diabetic with lower back pain group. The only exception was the social relations domain. In this domain, the results were high ranking for both groups, but there was no significant differences between the two groups. 64.6 for diabetic group and 64.2 for diabetic with lower back pain group. The social relations domains results may be expounded by the distinctive local society, which is characterized by exceptional, intense, and penetrated relations between people disregarding the existence of their diseases or the level of their health status. Contrary-wise with pre-intervention results, there were no significant differences between the two groups in post-intervention quality of life, whole scale, and subdomains data analysis as it's shown in graph 8. But similarly with pre-intervention results, the weakest results was the result of the physical domain. 61.9 for diabetic group and 62.1 for diabetic with lower back pain group. And inversely with pre-intervention, In post-intervention, we can notice that diabetic group with lower back pain had better but not significant outcome for physical domain than the diabetic group. This may be due to the positive functional effects of the exercise program in decreasing lower back pain, beside the improvements of physical abilities. According to the statistical analysis presented in the graph 8 of post-intervention quality of life, the high-ranking results was the result of social relations. 73.6 for diabetic group and 73.2 for diabetic with lower back pain group. And this is different from the result of pre-intervention, where the high-ranking result, as it presented, was the result of environment domain. By comparing the pre-intervention with post-intervention results of quality of life, as it presented in graph 9, we can accentuate that the formulated exercise program had certainly elevated the quality of life of the patients of the two groups, and at the same time, it was proficient to minimize the differences between them and close to the level of non-significant differences. After expounding the results of quality of life of our sample, it's still crucial to answer three vital questions regarding gender and tendency. The questions are: first, are there differences in quality of life between males and females in present sample? Second question, if yes, is the formulated exercise program competent to modify these differences? And the third question, is the formulated exercise program improving the quality of life in progressive tendency? To answer the first questions, which is, are there differences in quality of life between males and females in present sample? We compare the results of quality of life of males and females in baseline or pre-intervention phase, as it presented in graph 10. The results indicated that there were no significant differences between males and females in social relations and environment domains. This, as it mentioned earlier, because of the intense social relations and highly appropriate environment. However, there were significant differences between them in two domains, physical and psychological domains. This may be due to the fundamental divergences in body build, body composition, and psychological progressions development between the two sexes. To make the answer of the second question plentiful clear, which says, is the formulated exercise program competent to modify the differences between males and females? We compare the result of quality of life of males and females in post-intervention stage, as it's shown in graph 11. We found that no significant differences existed between males and females in post-intervention quality of life results. And this simply means that the formulated exercise program was competent to modify the differences between males and females. And this result, the efficiency of the formulated exercise program, may be supported by the result of the whole sample quality of life in pre and post intervention, as demonstrated in the graph 12, where it was efficient to elevate the quality of life of the whole sample significantly in post intervention compared to pre intervention. Now, the answer of the third question, which says, is the formulated exercise program improving the quality of life and progressive tendency? The answer is summarized in the line plot graph 13, where we can distinguish between the two groups. Both groups had progressive tendency in its improvement process, but diabetic group with lower back pain had inconsiderable break between week 3 and 4, a kind of a steady state. By reviewing the diabetic group with lower back pain patients' feedbacks, this slight break can be vindicated by the appearance of the muscle soreness in the third week and by the incremental difficulty of a progressive exercise program. On the other hand, when we view a week after week development curve of quality of life of the entire sample, as it presented in graph 14, we can undoubtedly determine that our sample had enhanced the tendency of their quality of life as they proceeded in the formulated exercise program. Dear friends, as it presented in details, the simplified exercise program was confidently appropriate for weight reduction and for enhancing, improving quality of life of inactive, overweight, and obese diabetes mellitus type 2 patient with and without lower back pain, and for the reconfirmation of the vital role of exercise programs, and for the reflection of our patient views. We mentioned the exact words had been said by a patient of our sample after completing the exercise program. I just borrow the exact words being said by one female. She says, maybe you cannot cure us from diabetes mellitus, but you were able to positively change our life in a short period. You were able to make us enjoying our life, enjoying our daily life, and to make us more functionally independent. Wishing you an informative, successful conference, and see you as soon as it possible. Thank you for your attention.
Yeah, Dr. Alex asked me how many minutes should an obese diabetes patient do his or her exercise session. Well, it's depend on the training ability of the patient, depend on the age, gender, but actually our exercise program in this research was asking for at least 90 minutes. Other question from Mr. Ivan Trianto, who said, a message here, why diabetic had better compliance and effects of exercise? Are the HbA1c levels of diabetic individuals would relate to the effects of exercise on them? Thank you in advance. Well, I'm sure it's advanced, but there were no ability in our research to measure the blood parameters or other parameters. Our aim as that research was depend on just two aspects: weight reduction and quality of life. And both were improved according to the statistical analysis. Which your idea about the hemoglobin or HbA or other blood parameters, I think it will be more interesting and more accurate results if we could get blood results. Thank you for your nice and important question. From Rita Vonokuma, what were the protocols followed before intervention, and can you tell details of intervention programs? I've told you the program in table 1, I think. The protocol followed before intervention. We just choose those patients, as I mentioned before, who have diabetes mellitus type 2, dividing them into 2 groups. One are with lower back pain, with specific lower back pain, and the other without lower back pain. And mostly they were inactive, absolutely inactive. They do not participate in any kind of activities or sports. I think Ethan, yeah, have assess the quality of life in biopsychosocial aspects. Easily, it was simple to apply the WHO, World Health Organization, quality of life scale, which assess accurately the biological, psychological, and social aspects of quality of life. Any other question? Okay, I think that was the last one from Rita. Thank you so much, Rita, for your question.
Well, Dr. Mahmoud, thank you very much for your interesting presentation. It was nice to hear you. I wish you many success, and I hope that we meet again in future, in next time in Budapest. And I would like to ask Dr. Srikanth Babu Venga from India to give his talk, Diabetic Adhesive Capsulitis and Exercises. And I would like to ask the lecturer to keep the time, because we are too late and we have to finish our session at 6 exactly. So we have 20, maximum 25 minutes for each lecture. Please, Dr. Srikanth Babu Venga, start your talk.
Thank you very much. My name is Srikanth. I am a Chief Physiotherapist at Minara Medical Center, Minara Group. The topic for today's discussion is Diabetic Adhesive Capsulitis and Exercises. So we are going to discuss about adhesive capsulitis today. The contents are diabetes and adhesive capsulitis, symptoms of adhesive capsulitis, treatments available for adhesive capsulitis, and exercises to improve adhesive capsulitis. Shoulder pain. Shoulder pain is one of the most common complaints of patients with diabetes that causes motion limitation, functional disability, and decreased quality of life. There is higher prevalence of shoulder disorders in patients with diabetes. Adhesive capsulitis is a term used to describe an insidious onset of pain and movement restriction in the glenohumeral joint. Adhesive capsulitis, also called as frozen shoulder or pericapsulitis or humeroscapular fibrositis. Most authorities agree that adhesive capsulitis is caused by the inflammation of the joint capsule and synovium that eventually results in formation of capsular contractures. The pathophysiology that predisposes patients with diabetes for developing adhesive capsulitis is not well understood. Anyhow, there are many studies suggesting that the root cause of adhesive capsulitis is a glycosylation of the collagen within the shoulder joint capsule triggered by the presence of high blood sugar. Clinically, there is global loss of both passive and active range of motion of the glenohumeral joint, with external rotation being the most restricted physiological movement, thus leading to functional limitation. Primary adhesive capsulitis affects about 2 to 3% of general population, but is reported to occur in 10 to 29% of those with diabetes. That means the adhesive capsulitis occurrence in diabetes patients is higher. It affects females slightly more than males and is seen as about 40 to 70 years of age. Bilateral involvement occurs in 10 to 40% of cases. There is a study done by Bridgman in 1972. He studied about 800 subjects, 800 patients with diabetes, and he observed about 800 patients who are non-diabetic and observed for the adhesive capsulitis. And he found out he recognized a strong association between diabetes and adhesive capsulitis. He found out of 800 diabetic patients, there are about 10.8% of patients who are having adhesive capsulitis. And then when he saw about 800 patients who are non-diabetic, he observed about 2.3% of patients having adhesive capsulitis. Studies also supports the association and reported a prevalence of 10 to 76% in type 1 and 7 to 30% in type 2 diabetes, as compared to 0 to 10% in general population. There are 4 stages of adhesive capsulitis. These stages of adhesive capsulitis is based upon the arthroscopic changes that is found, and it is given by Nevesier. The 4 stages of adhesive capsulitis are initial stage, freezing stage, frozen stage, and thawing stage. Some authors considered initial stage and freezing stage as a painful stage. If we observe the 4 stages, initial stage is about 3 months, where the patient starts the pain and the range of motion starts to decline. There are inflammatory process. The inflammatory process starts, but there is no capsular contractures. The freezing stage extends from 3 months to 9 months, where the patient's pain increases. There will be chronic pain and range of motion further decreases. Here the synovitis starts and the fibrous adhesions are formed, which later develops into capsular contractures. The 3rd stage is the frozen stage, which extends from 9 to 14 months. Here the pain starts to slow down, but the range of motion is significantly decreased. There is marked stiffening of the shoulder and substantial loss of range of motion. Here the synovitis starts to subside, but the capsular contractures increases. The 4th stage is the thawing stage, which extends from 15 to 24 months. There is minimal pain. The pain starts to decrease, and there is improvement in range of motion as well. The active fibroplasia also decreases and it is completely subsided. When we see this chart, the time is taken on the x-axis and severity on y-axis. The first stage, painful stage, the initial and freezing stage together, and the frozen stage and thawing stage, if we see, the pain and range of motion, the pain starts to increase in the first stage. In the freezing stage, the pain starts to increase and the range of motion starts to decrease. Then going to frozen stage, pain slowly decreases and the range of motion, slowly the range of motion also limited. And going to the thawing stage, the pain almost goes down and the range of motion is improved, but whatever range of motion is available, it is available. If you see the symptoms of the patient with adhesive capsulitis, first marked symptom is the pain. Here the pain is insidious and acute in onset. It is present during activities, and sometimes if the disease condition is aggravated, the pain also is present during resting time. This pain is more in the night time, and sometimes because of compensatory movements, the patient can develop upper back pain. Coming to the stiffness of the shoulder joint is prominent, which can be restricting the functional activities, especially when the patient have to do overhead activities such as dressing or grooming. A prominent feature called girdle hunching maneuver is present, where the person glenohumeral movements are compensated with the scapulohumeral movements. The patient try to move the scapula instead of the glenohumeral joint. The limitation of movement follows a capsular pattern where external rotation range of motion is restricted more compared to abduction than compared to internal rotation. That means here, among all the movements, external rotation range of motion is restricted more. Coming to the treatment of adhesive capsulitis, till date there is no standard medical, surgical or therapy regimen which is universally accepted as most efficacious treatment for restoring motion in patients with shoulder adhesive capsulitis. Non-surgical interventions may include physiotherapeutic interventions, exercise therapy, pain controlling medications and steroid injections. Let's say if the condition is not improving, the final option is a surgical approach where the surgeon can do a surgical arthroscopic repair, or if it's not responding, the final solution is shoulder arthroplasty. There is a study done by Hanafin. The study tells that exercises are proven beneficial, especially active and passive range of motion exercises have shown to improve shoulder range of motion in all planes, thus increasing the functional activity of the person. There is another review done by Syed. He tells that active range of motion exercises, self-stretching exercises and joint mobilization techniques have been reported by several systematic reviews to reduce pain and restore shoulder range of motion and functions in patients with adhesive capsulitis. Coming to the exercises for adhesive capsulitis following all the 4 stages, in the first stage and the second stage where the pain is higher compared to the range of motion, here the pain is higher and the range of motion starts to decrease. So the main goals of treatment here is to improve the pain and to improve the range of motion. For decreasing the pain, we use various pain relieving modalities like applying hot pack or using some electrotherapeutic modalities or using some other alternative ways. And coming to improving range of motion, there are many exercises which are proven beneficial for improving the range of motion. We have many forms of exercise such as pendular exercises, wand exercises, wall exercises, towel stretches, passive stretching and active stretching exercises which can be done at home or which can be done at the exercise center. Coming to the third stage where the pain is minimal but the range of motion is significantly reduced, a thorough aggressive stretching program should be introduced to improve the range of motion. For non-responding cases, surgical intervention may be needed. Sometimes manipulations can also be helped to improve the range of motion. And coming to the fourth stage where the pain is very minimal and there is progressive improvement of range of motion, here an individual has to recover range of motion by strength and conditioning exercises. Coming to the exercises, for improving the range of motion exercise, the most important exercise is a pendular exercise where a person can be leaning forward and the affected limb or the hand have to be moved either in the front and back directions or in the side directions like in a pendulum. It is a gravity assisted movement, so patient should not use any muscle contraction, but using the gravity they can move the hand front and back and in sideways, or they can do small circles like clockwise circles and anti-clockwise circles. This is repeated 5 to 10 times, but as a convenience we can ask the patient to do 3 sets of 10 repetitions which are proven beneficial. Another form of exercise to improve the range of motion is moving the affected hand with the normal hand, where here we ask the patient to lie down and ask them to support the affected hand with the normal hand and move the hand all the way until the end of the range of motion. So the patient is advised to move the hand for 10 times and give a small break and continue it for 3 sets. This can be done by 5 to 10 times. Another form of exercise to improve the range of motion is a wand exercise and the stretches. Wand exercise is a form of exercise where a person can hold a small stick and try to hold the stick with both hands and move the stick from sides so that it causes movement at the shoulder. So this movement can be done also in 3 sets of 10 repetitions. Another way to improve the range of motion is a passive stretching, where the affected limb is held by the normal hand and the hand should be taken to the opposite shoulder. When the patient feels a stretch feeling, then they have to maintain it for 15 seconds and then release. They have to continue it for 5 times. Another form of exercise to improve range of motion is called towel exercise. Here the patient is advised to hold a towel from behind, where the affected hand, where the problematic hand should be behind, and the holding the one end of the towel, and the other end of the towel is held by the normal hand. Here with the normal hand, slowly we have to move the towel up so that it causes a posterior thrust over the affected shoulder. This also can be done for 3 sets of 10 repetitions. Another interesting exercise which improves the shoulder range of motion is a pulley exercise, where the person is asked to hold a pulley, overhead pulley, and slowly they have to move until the end of the range of motion and continue moving it for about 3 sets of 10 repetitions. This is an assistive form of exercise which improves the range of motion. Another form of exercise is the wall exercise, where the patient is asked to move the fingers as though like crawling on the wall. They have to move in front ways or in the sideways. They have to move until the end of the range of motion. When they feel the pain, they have to maintain it for 15 count and then they have to come down. They can repeat this exercise also 3 sets of 10 repetitions. There is a study done by Pallavi Rawat on rotator cuff strengthening. It is a randomized control trial where she gave exercises or strengthening exercises using a TheraBand, or she used about 1 to 2 kgs of dumbbells as well. About 8 to 12 repetitions for 3 sets were given in each session for about 12 sessions. She found out that introducing rotatory cuff strengthening program along with range of motion exercises is beneficial for the patient to recover faster. Take home message from this description is diabetic adhesive capsulitis is a self-limiting disorder. Early intervention yields good results. Pain management along with active and passive range of motion exercises to be started as early as possible. Strengthening the shoulder girdle muscles prevents atrophy of muscles, further accelerating the recovery of process. These are my references. The main challenge for successful NCD prevention is not what we do, but how to implement the needed action. That is where the World Conference on Exercise Medicine is doing. Thank you very much for the organizing committee, especially Dr. Lee and Dattosri Jessilai for organizing this wonderful World Conference on Exercise Medicine. Although during this pandemic time, organizing this on a digital platform is a creative idea. Thank you very much. Thank you. What is your opinion? Yes, truly said. Usually, as I told you, shoulder adhesive capsulitis is a self-limiting disorder. If you're not doing any treatment also, it will reduce eventually, but it will take over a period of time. So that is the period of time where the patients cannot take the pain, where the limitation of movements will decrease the quality of life. So this is the period where we intervene and help them to come out of this position, to decrease the pain and to improve the range of motion. And then we have another question from Schwan. What's the difference between diabetic and non-diabetic patient with adhesive capsulitis? Okay, it's an interesting question. Adhesive capsulitis, there are many reasons. It can happen to a person who is diabetic, and it can happen to a person who is non-diabetic as well. But when you see, as the research tells, mostly people with diabetes have high chances of developing adhesive capsulitis of the frozen shoulder. This is on research. But non-diabetic patients also have a chance to develop adhesive capsulitis. So the treatment line basically will remain same. Only the thing is, let's say like diabetic patients is there, we have to take care of repetitions of exercises. We have to give frequent intervals of rest while treating the patients. And then we have another question from Xavier. What treatment is suitable for reducing the adhesive capsulitis? As I told you, like exercise is a very prime or important treatment strategy for improving the adhesive capsulitis. Let's say like active inflammation is there. It can be treated medically by using NSAIDs and then painkillers. But when coming to conservative treatment, physiotherapy by means of various pain reducing modalities along with exercises will help to recover the person faster who's having adhesive capsulitis. We have a question from Rita. Why frozen shoulder to diabetic patient? As I told you, like diabetic patients are more prone for developing this adhesive capsulitis because the free flow of sugars and then the formation of crystals in the capsule of the shoulder, they have high tendency in diabetic patients. It results in capsular contractures, which may ultimately lead to adhesive capsulitis. That is the main reason. Any more questions? We don't have any questions here. Is there any other questions? Okay, we have a question from Dr. Mahmoud. Why the major concern of exercise were on hands and arms only? Okay, actually, we are talking about shoulder adhesive capsulitis. That's the reason I'm specifically talking about the shoulder exercises. Let's say like if we are talking about diabetic patients with different problems, we might be like, you know, specifying exercises for different parts of the body. Okay, we have another question from Mohit. What do you advise for physiotherapists? Which technique is better to use for in the treatment, Mulligan, Maitland, or Syriac? Okay, coming to manipulations. Okay, along with pain management and exercises, there are some other specific things called manipulations which can improve the range of motion. Actually, here the active range of motion and passive range of motion are limited. So manipulations will play an important role to decrease the capsular contracture, at the same time improving the range of motion. When coming to Maitland, Mulligan, and Syriac, each technique will have its own importance. Like, you know, Mulligan concept, Mulligan mobilization is very important to improve the range of motion. And then Maitland's, where we go for glides, that one also will improve range of motion. There are various studies done on Mulligan's and Maitland's and Syriac's manipulations, where the results are different. And here we have to observe, like if we see in adhesive capsulitis, especially in diabetic patients, there is something called capsular constraint mechanism, where in this capsular constraint mechanism, the kinematics of the shoulder joint will be different. Here, the concavo-convex rule will work differently. So the manipulations, when we are doing the glides, the gliding will be, we cannot follow concavo-convex rule here. So we have to keep in mind when doing the manipulations here. I think this answered my question. Yes. Okay, this is the last question, I believe. So I would like to pass on the session to Chairperson, Dr. Berkes. Thank you everyone.
Okay, thank you very much, Srikanth. It was a very, very nice and interesting presentation, and congratulate you. And we move on the next speaker from China, Dr. Yuling Wang. His talk is Research Trends of Sports Injury on College University Students from 2000 to 2019. It will be a bibliometric analysis. Please start your lecture, Dr. Yuling Wang.
Okay, thank you, Professor. Okay, let's start my presentation. It's my honor to join this very great event of WCM 2020 this year. I joined WCM last year. It's a very interesting and very important moment for me and for my team. Okay, today I want to share a topic. One of my research students, she summarized the papers about the sports injuries among college students from 2000 and to 2019. We all know the sports injury in the college or university student is a very common problems when they perform the different sports exercises. So today I just want to summarize the key message and also to share the studies we concluded after the systematic reviews to analyze what's the event, what's the reasons come from the sports injuries. Okay, we all know the definition of the sports injuries is referred to the types of injuries or functional disorders during the sports or exercises. One paper published in the British Journal of Sports Medicine, they summarize the sports injuries and illness classification systems. That's very important. That's a milestone of the consensus version. We can reference this in important reference if we need it. Another definition, according to the IOC Manual of Sports Injury, that means a sports injury may be defined as damage to the tissues of the body that occurs as a result of sports or exercise. The Olympic Committee's consensus statement, they also report the epidemiological data on injuries in sports in 2020. They also published this report in British Journal of Sports Medicine already this year. And we all know the reasons may come from this part of reasons. And one is depression, anxiety, or psychological status. Like sometimes the athlete or the professional or trainers, they have very high stress or very high strain when they conduct the sports or exercise. That's one key reason come from of the sports injury. Another part is talking about environment, and another part is physical activities, physical factors. If we classify the sports injury, usually we classify the damage issues, includes a skin, bone, joint, nerve injury, all defined by the contact with outside open injury or close injury. The open injury is usually is a severe. The injury time defined as acute, subacute, or chronic injuries. Severity is mild, moderate, or severity. This classification is very easier and not complicated. But when we go back to the epidemiology, if we look back to the part of the body's injuries, we can see the indication of forearms. It's a higher prevalence of the sports injuries in different sports like rugby, soccer, basketball, like gymnastics, or touch football, and like tennis. That's forearms injuries. For the head, it's cricket or field hockey, also the rugby or American football. We all know the famous injury, the popular injury is concussion. So the annual economic expenditures of sports injury in China was estimated to be equivalent to 12.5 billion US dollars. That's very high expense. So that's researchers have found the minor sports injury could affect the ability to perform the daily activities and the participant performance of any sports or exercise in their life. They published the Journal of Science Medical Sports in 2006, but after almost 14 years ago, they made change. That's why our team was conducting another new epidemiological study to conduct the study throughout the country. We selected the majority of the university's students. That's a very large number. Is that big data? We will publish later. So let's review some previous studies on sports injury. This study, they indicated, the physical activities level and the sitting time of a sample in university students. They examined the association of physical activities with percent body fat. That means the men had high levels of total and leisure physical activity than women. All participants have had a prolonged sitting time. That's almost half people are having a sitting time of more than 10 hours per day. That's a very big problem. So this study conducted in another country, but in the different countries, so we all know the situation is becoming severe. And another study reviewed that's conducted in China. They indicated the physical activities related injuries. That's a public health concern among the Chinese university students, which could provide direction for targeted the interventions. There's a specific injury mechanism to reduce the physical activity related injuries. That's very interesting study. Another study that talk about the behavior, and that means the survey sampling process conducted more than 10,000 undergraduate students from 50 universities in China. They reviewed the prevalence and behavior is changed, especially in the sitting or sedentary lifestyle. And another study also reviewed the continued examination of interventions aimed to reduce the incidence, severity, or recurrence of that's a lateral ligament complex ankle sprains in National College Athletic Association sports. So now I just move to material method of our study. We summarize the studies from more than 500 studies. We selected 469 studies. We analyzed by the size space V and to analyze the knowledge PIP map of publications, journals, countries, institutions, authors, keywords, occurrence, and the strongest citations burst, and among others. And because of the limited time, I just briefly summarize the findings. That's the size space in introductions. Let me skip it. we can see the results of this analysis of publication output. The research output concerning sports injury amongst college students generally exhibited upward trend in these past 20 years. And the average annual numbers of articles published only 23. But in the last 2 years, the publication is more than 50. The document type come from the articles, the papers, reviews, the media abstract, editorial material, and book chapter or reprint. And the distribution of countries and institutions, we can see the paragraph. That's most publications come from the United States, Australia, England, Canada, People's Republic of China, and Poland, Southern China, Ireland, Germany, Turkey. And the institutions come from University of North Carolina, Indiana University, University of Virginia, University of Arizona, UT, and the UBC, and other institutions. For the countries, most of the output come from the developed countries and the developing countries. That means that they may have more populations, most college or university students join the more physical activities. They may have the high risk of sports injury. If they still stay in the sitting time longer, they may have less chance. They may have another chance to have other injuries. So for the journals of athletic training, they published around almost 50 publications. Another ranking comes from the Journal of Strength and Condition Research, Clinical Journal of Sports Medicine, American Journal of Sports Medicine, and the fifth is a Journal of Sports Rehab. The authors, the top 5 authors come from these key persons. And for the keywords of the publication related to sports injuries in college or university students, the hotspots in subjective area includes sports exercise-related injury, traumatic brain injury, concussion, prevention, performance, epidemiology, risk factor, and so forth. There's indications come from these publications. That means the concussion and the TBI is still the concern for all of the research or clinical physician or physiotherapist. Okay, for the last part, I want to share the discussion. The general trends of sports injury among college students. The output of sports injury among college students was increasing. That means the publications is increasing, but for the prevention of the sports injury, we may pay more attention how to prevent the severe sports injuries, how to prevent the unpredictable sports injuries for the college students. We all know the young generations, they are elite, or they may to be the elite, to be the key persons for the future society. If they have the different sports injuries, they may have more influence. And second is the preventing types of sports injuries include the brain trauma injuries and concussions. Just mention about it. There's severe injuries. They may have different impact for the college students. how to enhance the prevention equipment, how to prevent these severe injuries. They may adjust, may change the regulations if it's possible. They may have another part of like alert, like the helmet changing. Okay, the third is relevant and interventional measures and risk factors of sports injuries were discussed in the past publications. How to measure the risk factors, how to define the risk factors of sports injury, to build up the new models. The new models may help us to prevent. We all know if we stand in the rehabilitation level, or we stand in the view of the physiotherapist, that's the latter. We need to promote the prevention, how to prevent the sports injury. And the last part is the majority of the articles was epidemiological studies, the cohort studies, the clinical interventions, like the high levels randomized control trials. We can also pay more attention on this. And the research hotspots and emerging trends also indicate the keywords, by the keywords, the skeletal muscles, the damage, the athletic injuries, strength. Strength is talking about the psychological side, the performance, and other keywords. We need to pay more attention on that, how to prevent, how to treat, how to pronounce. And to summarize the hotspots and emerging trends, there's the cycle talking about the epidemiology, prevention, especially for the typical football player, the higher school, college, or later the university students, to prevent the severe or moderate or mild sports injury. That's the profile we need to study in the future. And among the studies of sports injury in the college students, the TBI had a highest occurrence rate. It's still high risks for them. The research hotspots in this field, the concussion in the brain injury is also a popular research focus. And the previous studies on the impact of sports injury among the college students also provided reference for athletes. To understand the mechanism of brain injury and sport-related concussion, the epidemiological design was commonly adopted in the published work included. And the research, especially for epidemiological research, played an important role in the multidisciplinary connections in these disciplines. And go back to this study, talking about the prevention measures, the crucial for both academic and practical purposes I mentioned before. A number of studies has shown that certain intervention could prevent the occurrence of sports injury, such as the use of protective facilities, change in the training methods, and the lifestyle modification. The lifestyle modification is very important. The electronic games, the long sitting study time, this may be another high risk factors for the injuries. College students. Okay, the last part is talking about the severe injuries, especially for the specific sports like a football player. And this previous study also talk about the monitoring and the recording of sports injury in high school at the great value to establish the incidence assessment as compared with the findings in university environments. Okay, the key points and problems we mentioned before, and that means how to prevent, how to aid to the existing knowledge, to know how to conduct our future study, how to compare the past 2 decades for the clinicians, research institutes, policymakers, injury prevention measures. And our analysis also offers a cross-cutting perspective of the up-to-date research work on the subjective area of interest in terms of identifying the trends related to sports injury among the young populations, disclosing the productive research and contributing to the institution and disconcerting the quality of previous works. And the problems of the existing research also talk about the quality, quantity and quality of publications, and the multiple data simultaneously were not possible due to the limitation of this software site space. That's our limitation of this work. Okay, that's conclusions. Okay, and the research output of sports injury among college students had presented an upward trend in the past 2 decades. However, the number was related to too small, and research was still in infancy stage. Okay, the hospitals focus on the TBI injury and the prevention risk factors of sports injury. And the specific injury analysis, psychological factors for the sports injury is also associated with sports type, and they may become a new trend. The future multifaceted and multidisciplinary studies towards emerging directions in sports injury in college students are warranted. That's my sharing, and thanks again. Thanks for Professor of the moderator, and thanks for WCM's kind invitation. It's my honor to join this section. Thank you very much. Professor? Okay, maybe the time Muhammad has, okay, how adjustment to college as a reason may affect sports injury. How could you improve the efficiency of sports injury in rehabilitations? Just mentioned about before, I think the prevention is very important. If we want to improve the efficiency of sports injuries rehabilitation, we need to early diagnosis, early intervention, especially for the patients in visit to the hospital. We can join the orthopedic team. We can go to the sports injury, sports medicine center to join together with them. And your presentation is more related to sports medicine or exercise medicine. I think it's both sports medicine and exercise medicine. You know, how to use the exercise is medicine's concept to utilize on the recovery and improve the performance of the injuries patients, injuries college students. That's our key words of our conference, the exercise medicine. Okay. Any questions? Okay, the question comes from Dr. Giro. What's possible specific intervention to prevent injuries among college varsity players in prospective events? I think usually we need to educate the coach and the students to improve the efficiency of warm-up section, and also need to improve their fitness and strengthening flexibilities when they conducted the sports. That's a key section. Okay, any other questions? Okay, Professor Chairman, maybe the time?
Yeah.
Yeah, thank you.
Thank you very much, Dr. Yuling. It was a really, really good and nice presentation, very interesting for us. I congratulate you. And actually, we will finish our session. I think that it was a very interesting and fruitful session, having a lot of very, very good and very experted lecturer. The topic was really interesting, and I think that they will help us in the future practical work. And as I close our session, I would like to ask Miss Shena from India, to start the workshop for the pilots. Please, Miss Shena. Sneha. Excuse me.
That's completely fine. Hi, everybody. Sneha here. It's fantastic to be a part of the World Conference of Exercise Medicine, and I really genuinely thank Dr. Lee for accommodating I was actually supposed to conduct the workshop on the 3rd, but I hurt myself. So, and it kind of, I think everything works out for the good at the end of the day. Because I think the kind of lectures that were there, the presentations that were there today, all leads towards Pilates. So just a small brief little history about what Pilates is all about. It's who is Pilates. Pilates is a form of exercise that was created by Joseph Pilates. He didn't call it Pilates when he was there. He called it the method of contrology. And he created these movement patterns, and that really helped the soldiers who were a part of the World War II to help them recover better, not just physically recover from injuries, but also become mentally stronger. So this is a fantastic mind and body related movement. Like Dr. Rehan was really stressing earlier during the presentation, and Dr. Istvan, about why it is so important for corrective techniques. And that kind of brings me to the actual reason why people should be doing Pilates is for conditioning reasons, so that you can prevent injuries from happening in the first place. And regular practicing of Pilates will ensure to see that all your basic movements and your postures corrected, so that there's lesser chances, or there's lesser risk for encountering injuries. And I think Dr. Edgar was also stressing about sleep, stress reduction, and that we're all chronically stressed in today's world. And Pilates stresses so much about diaphragmatic breathing, about breathing and synchronizing breath with movement in every exercise that we do, which is fantastic, because that is exactly what we need today as a medicine, right? We need to learn how to breathe. We need to learn to be in the present moment, so that we can, kind of really embody the experience. We can understand, become more intuitive. We can get feedback from our body when it's trying to send us signals if something's going wrong. I made a few small notes with all of the lectures, and it was really fantastic. And Dr. You said something about pelvic floor, and then that is something, again, that we really focus into Pilates, right? Every exercise movement restructures how pelvic floor connection needs to be established. Sometimes people are doing way too much more. Sometimes people are not really activating the pelvic floor muscles at all. So you kind of really establish activation of the pelvic floor and the core muscles, or the abdominal muscles, the anterior lateral abdominal muscles, just to ensure that there's a proper intra-abdominal pressure that's happening, which establishes, core connection, which establishes structures, breathing, and with pelvic floor, everything working in synchrony with each other. And I mean, this is the best, one of the really amazing movement methodologies that's available in the world today that needs to really be put out there. And some basic exercises that I will kind of start functioning and showing you guys. Feel free to join me and do them with me. We'll start off with the basic, breathing exercises, some pelvic tilts, pelvic rotations, and stuff like that. How many more minutes do I have? We can start doing some basic exercises. Dr. Rizwan? Okay. We're going to start by lying down on the mat. I hope you all can see me, okay? So first of all, re-establishing breathing patterns without really complicating the cues of bony landmarks or anatomy for people is, use cues that are really comfortable with a lot of people, which is, for example, rib cage, right? Think of rib cage. Inhale to expand the rib cage to the side. Exhale to connect and bring the rib cage towards the center. Inhale, open up the space between the bottoms of your rib cage, and exhale to connect the two towards the center. And then we kind of move on and take our attention towards the hip bones. People are easily able to recognize the position of their hip bones. Inhale to establish the breath, and inhale to expand the space between your hip bones, and exhale to connect the space between your hip bones. Inhale and exhale. Inhale, breathe in with your nose, and exhale, breathing out with your mouth. Now we'll start doing some basic pelvic rocking movements, which are very primal movements, which most people are not generically aware of. What happens in most of the exercise sessions is we kind of cue them how to lie down, where to sit, how to position their pelvis. And that's not necessarily important, because people need to learn how to move their bodies intuitively, whatever is available to them, right? Today's neutral may not be neutral for tomorrow. So, how we start cueing is kind of allow them to position themselves, pelvis in nicely comfortable position. Inhale, imagine a glass of water on your pelvis, to drop that glass of water towards the floor and return it back towards the center. And as you go into posterior tilt, which will not be cueing as a posterior tilt, exhale to curl the pelvis or rock the pelvis up, and imagine as if the glass of water is dropping towards the body. So kind of helping them understand that rocking movement that's available around the pelvis, it becomes really easy for them to understand where that comfortable position, where their neutral is today, right? And work with that, which is very critical and important. So inhale, exhale. Inhale, rock the pelvis forward. Exhale, rock the pelvis backward. And the other most important cue that we always use is breathing out with the mouth. And it's proven, research is, there's written research there, there's literature available to prove that inhaling through the nose, and as you exhale with the pursed lips with your mouth, it immediately activates your transversus abdominis and your pelvic floor. There's an extra activation that happens as if the brain kind of registers that there is some kind of additional movement that's going to happen, which is why there's an activation of the pelvic floor and the transversus abdominis. So you kind of exhale out with the mouth. We're going to do a generic, simple, basic movement of a bridge, but the cues are very critical and important here, so that the person who is executing it finds it really easy and less complicated to execute it. Inhale to rock the pelvis forward. Exhale, start rocking the pelvis backwards, pushing the feet into the floor. Start rocking the tailbone towards the pubic bone. Bring the pubic bone towards the belly button, and start rolling the hips up into the ceiling. Inhale, you're going to stay right there. Exhale, melt that chest down. Articulate the spine, one vertebra after the other. Let the belly button hit down the mat. Drop the pelvis down. Finally, drop the pelvis back forward again. I'm going to do one more. Exhale, rock the pelvis back. and then push the feet into the floor. Take the tailbone to the pubic bone curling towards the belly button, and then take the hips up into the ceiling. Inhale to stay right there. Exhale, release it back one vertebra after the other, and dropping the pelvis back down. Now, these small movements are so necessary and important because it mobilizes the spine. It helps them to activate their glutes and hamstrings, right? Which is very important because usually most of the time what happens, people are always in a seated position. This helps them into activating the opposing muscles of your hip flexors, and kind of gives them that opportunity to leave them nice and open. Now, if you want to challenge the patients or the general population a little bit more, then you can increase the work by dropping the pelvis a little down and then giving them small pulses there. So they kind of work just within that zone. Very important and very critical. It's not about the height that's important here. It's also about how comfortable they are with the movement. Some people, because of extremely tight pelvis, could be here somewhere, much lower than the way you want them to be. So this is okay to start here and then drop them down and then lift them up and then slowly lowering it down one vertebra after the other and then releasing it down. Now, the other exercises that you could do while you're lying down supine, plain and simple, right? Even people who have had lower back issues or who have been sedentary, who've been immobilized, if they are flexible to move around their legs, they could do these exercises on the bed itself. And then simple small exercises such as keeping the pelvis stable, inhale to lift the leg up, lowering down without rocking the pelvis entirely. Inhale, lifting it up, exhale, lowering it down. At every moment of the time, the client or your patient's focus is completely on the breath and then trying to synchronize that with the movement in every single exercise. And what that basically does is it brings the attention of your patient or your client to the present moment, right? Most of my clients usually express the basic fact that they find the Pilates classes meditative in nature, that they have no chance to think about anything else that's happening outside of that session because all of their attention comes down to this place. So this is a great exercise to kind of bring in the parasympathetic nervous system into play, which is so crucial and critical to kind of bring down the stressors or the cortisol levels of the body. You can challenge this exercise a little bit more by trying to imagine that they're shortening the space between the rib cage and the pelvis, so there's no gap between the back and the mat. And then you can ask them to bring one leg up, support them by bringing the other leg up, and then you kind of ask them to do toe taps right there. So this can be another challenging exercise to add right there. And every time you're going to focus on the breathing. It's also not about the pace of the exercise, slow and steady. You can feel free to add many props to this, right? This is just mat-based exercises right now that I'm going to be showing, and then slowly releasing it back down. Again, the same thing, supine. We could do side lying exercises where both the knees are bent. And this is a great exercise. Most of the Pilates exercises that you will be looking at teachers teaching have a huge focus on your local stabilizer muscles, right? Which are very, very important to ensure the proper hierarchical firing of muscles that are happening in the body, so that when they're doing ballistic moves or athletic training, they are ensuring that these local stabilizer muscles are properly functioning, right? Because they're not fatiguing. They're used to the kind of training that they need to be providing them. And extending the legs on the other side. The length is very, very important here. Inhale to lift the leg up. So it's not a very passive exercise, all right? So you're not getting the movement Jane Fonda style all the way from there and then just lowering and lifting. You're keeping the length in the opposite leg. You're really thinking of keeping the length in the head region. You're constantly elongating the whole body. Inhale, you're lifting it up, isolating the movement from the hip joint to ensure that your glute medius is basically targeted or focused. So inhale to lift up, exhale to bring it down. Inhale up and exhaling down. Inhale up and exhale down. And then we can do a few circles there. Inhale and exhale. Inhale and exhale. I'm still trying to get the work done only from my hip joint. and not getting it from my waistline. I don't want to increase the height of my leg because then the work starts to come and appear from the waistline. So I want to keep the length there. Really think of hip hike, yeah, reaching out with the hip towards the other end. And then I'm going to reverse the circle. This is a huge burner. People are going to really feel a lot of work in this area, right? And then circles around. And then you can extend both the legs. You can work with abduction and adduction, both the legs lifting up and then lowering down. This is a little bit more challenging. And then you can ask them to go into some kind of an arch and then releasing it down. Lateral flexion and then challenging them a little bit more. And exhale up and then inhale. Exhale up and then inhale, releasing it down. I'm going to repeat it on the other side, just in case some of you are doing it with me. Changing directions. We're just going to be doing 5-5 on each side. Extending the leg, really lengthening the top leg, focusing on the breath, focusing on pursing the lips while breathing out the air. Inhale, lift it up. Exhale, you can also work the ankle joint along with it. Plantar flex the ankle as you lift the leg up. Dorsiflex the ankle as you bring it down. Inhale up and exhaling down. 3 more and down. Keep reaching with the leg. Last 2 and down. 1 last one and down. Keep the ankle pointed. I'm going to stay right there in parallel. You can see that I'm not really lifting the leg way too high. I'm keeping it in line with the rest of the leg, right? The hip joint. And circles. Clockwise circles. And exhale. At all time, I'm going to try and keep the connection in the body. Right? I'm going to be stable throughout my pelvis region. I'm not going to collapse like this, right? I'm going to constantly stay active. Think of bringing the rib cage towards the center. Think of bringing the hip bones towards the center. Inhale, and then I'm going to reverse the circles now. Inhale, half a circle. Exhale to complete it. Inhale, exhale. Last one. And then complete it. Then I'm going to extend both the legs and I'm going to lift them up. Both the legs together. And then I'm going to work on lateral flexion. I should technically have put my hand down even on the other side. There's lack of space there. So this is the right movement. Push the hand into the floor. Connect the abdominals as you reach up. And exhale. 1 last one. And exhale. And then releasing it down. We're going to be going into a quadruped position, which is another fantastic exercise. Actually, before we go into quadruped position, I like how Dr. Yew mentioned about doing Kegel's exercise, right? Doing Kegel's exercise is so relevant and so important because a lot of people have, inactive or laxity in the pelvic floor muscles. But there is another very critical, important point that I want to mention here is it's always the anococcygeal area that's always being given a lot of importance. But the area of the connection of the pelvic floor between the tailbone to pubic bone, that angle of connection is more slightly forgotten. So, in the center method of fitness, we've kind of designed a methodology where we've understood that we can do a small amount of lumbar flexion just to ensure that there is also that amount of pelvic, that's that part of the pelvic floor that kind of tends to get activated by doing a little bit of lumbar flexion there. So I'm going to put my hands down by the side, sitting really nice and tall. Knees are bent. On the exhale, what I'm going to do now is thinking of bringing, so there's no thoracic flexion that's happening. I'm initiating the movement from my tailbone, right? So I'm going to say exhale, tailbone to pubic bone. I'm going to bring the pubic bone towards the belly button. Now I'm going to bring the tailbone further to the pubic bone and then bring the pubic bone towards the belly button a little bit more. And then inhale, I'm going to lengthen up, grow tall. Exhale. 1, it increases the mobility around the pelvis, right? The rocking the anterior and the posterior tilt that's available around the pelvis, that's number one. Plus, it's also working on lumbar, the mobility of the lumbar spine. So exhaling and then inhaling. Exhale, initiating the movement only from the pelvis. The pelvis is rocking up, and right, it's going into posterior tilt there. And then inhale, lengthen back. Exhale, inhale. 2 more. Exhale, inhale. A huge abdominal work, this one. Exhale, stay back. We can add a ton of exercises on this one. I'm going to cross my legs here. Just do 5 of each. I'm going to go exhale, extend the leg, bring it back in. Exhale, extend the leg, inhale. So this is definitely a challenging exercise because you're not only focusing on staying in lumbar flexion, but you're also focusing on keeping the abdominals connected throughout this exercise, and then adding on the hip flexion extension, knee flexion extension. And then last one, and then I'm going to just go into flexion extension of the leg. And then lowering and lifting. Inhale, exhale. Breathe in, breathe out. Last one, and down. You can stay there, put the hands behind the head, and I can add rotation. And extend the leg. Exhale. And last 2. And last 1. Coming to center, drop the leg down. Put the hands back. I'm going to work on the other leg now. Exhale, extend. Inhale. 2. And 3. And 4. And 5. I'm going to stay there and extend the left hip, lift the leg up into hip flexion, and then lower it down. Last 3. And 2. And 1. Bring the leg back in. Add the rotation and release. 2. And 3. And 4. And last one, 5. Come back center, flex forward, and lengthen up and grow really tall. Now what you're going to do is we're going to go into the last exercise, which would be in a quadruped position. This is almost like your mini plank, right? A lot of people who will not be able to do the full plank, and also you see that they're compromising when they're in a full plank position. This is a great exercise to do. You're going to get their knees to come together. Feet are connected. Ankles are dorsiflexed. Arms in line with the shoulders. Knees in line with the hips. On the exhale, connect the inner thighs. And then without shifting the weight front to back, connect the rib cage, connect the hip bones, pick the knees off just a couple of inches. And stay there. Inhale. And then exhale, release it down. The other important thing here is you can start to notice if people are really weak in their serratus, what they end up usually doing is they'll end up sinking down in this area. So, you know, it's nice to push the hands gently into the floor so that they can pick the rib cage up instead of sinking into that area. On the exhale, I'm going to lift it up. Stay there. Inhale. Exhale, lower. Exhale up. Stay. And exhale down. Exhale up. Stay there. Inhale. And exhale, release it. After you finish about 5 to 10, we're going to end up holding ourselves in this position. Exhale, pick it up. Inhale, stay right there for 10 counts. 4, 5, 6, 7, 8, 9, and 10. And release it down. And then you can give them a good stretch by asking them to sit back into a short stretch. And then lengthening up, growing tall. I guess that was that. Okay. Thank you so much.
Yes, thank you very much for the wonderful session showing your exercises.
and I'm sure all of us will appreciate what you have taught us. Dr. Berkes has to be away for some urgent matter, and I would like to take this opportunity to, on his behalf, thank everyone for the wonderful session. A lot of knowledge learned, and I hope that we will put to practice what we have learned today. Before we end, I would like to thank the organizing committee for their hard work, Dr. Lee and Dr. Jessie Lai for organizing this session. And for your information, tomorrow we will have another day, and I hope that everyone will log in and continue to appreciate this wonderful conference that has been offered to us. And also, those of you from Malaysia, you can actually claim your CPD points, and from overseas, you can also do it in your own country. So without further ado, thank you very much to all the wonderful speakers for sharing your knowledge, and also to all the participants who have logged in to make our conference a success. Thank you very much, everybody.
Thank you so much.